Today, I will be talking about the monitoring of unfractionated heparin, which is still a challenge in our labs and for the patients, as mentioned before. And we will talk about the two main means to monitor unfractionated heparin, which are the APTT, which is the historical assay with advantages, but also limitations. And we'll talk about the anti-TNA assay, which is supposed to be much more standardized and which should give more reliable results, and we will explain why. So here is just as a reminder, the structure of fractionated heparin. Unfractionated heparin is a mixture of glucosaminoglycans chains of various molecular weight. And because these chains contain a unique motif, which is depicted here, which is a pentasaccharide, which is the minimal sequence required to bind to antithrombin and to potentiate the anti-10A and anti-2A activity of heparin. This is something which is important. And because the unfractionated heparin contains chains that are of sufficient length to inhibit thrombin, unfractionated heparin can inhibit both anti-10A, factor 10A and factor 2A or thrombin in a similar way. That's why the anti-10A to anti-2A ratio is equal to 1, which is quite different from what we have for low molecular weight heparin. So here is a representation of what happens when we inject heparin to patients. So first, heparin will bind to various proteins and cells. So the one of interest is the antithrombin to potentiate and to inhibit the factor 10A and factor 2A. Here, thrombin and factor 10A. But it will also bind to other proteins and cells, especially endothelial cells and macrophages. And this part of heparin, which is bound to endothelial cells, to macrophages, and to other proteins than antithrombin plus factor 10A or plus factor 2A, this fraction of heparin is inactive. So we will now focus on the monitoring of unfractionated heparin with the APTT. And this is a long story because it started in 1972 with a publication of a small series of patients, which is depicted here. So this is only a 234 patient study published in 1972. And those patients, they had a lower limb DVT diagnosis solely based on clinical criteria with no imaging testing. So this is a clear limitation of this study. And they determined that the therapeutic range would be a patient to control ratio of the APTT between 1.5 and 2.5. But we don't know which value was used as a control. So was it, for example, the median, the mean, or the upper limit of the reference range? Was it a normal pool plasma? So we don't know. This is quite a limitation of this study. And then it was translated that the 0.2 to 0.4 international units measured by protamine titration was corresponding to 0.3 to 0.7 international units per milliliter of anti-10A. One limitation of the study also is that the reagents that were available in 1972 are certainly very different from the ones that we have today. And even if we look at the ones that we have today, this is a study published 20 years back already, but most of the reagents, they are still there. And they compare the sensitivity of the different APTT reagents to heparin. And this is what is depicted here. You have on the x-axis, you have various APTT reagents, and on the y-axis, you have the APTT ratio corresponding to an anti-10A activity between 0.3 and 0.7. And you can see dramatic variation of the sensitivity. And even if you look at different batches of the same reagent, there are also differences that have been depicted. And if you look also at the inter-reagent and inter-instrument variability, you can see also that there are differences. And for those who are not working in the lab, but who are clinicians, you may not know, but there are different types of detection for the clot formation to measure the APTT. One is the mechanical detection, which is the historical system, the ones that we have at Stago, but there are also instruments working with an optical detection. And you can see that there are differences between these two systems for the same sample. And if you look at different instruments, you have these differences which are illustrated here. For example, if you look here, this instrument represented with black triangles give very different results from the one which is represented with the white triangles. And furthermore, if you look at the combination between the instrument and the reagent, there are also huge differences. So there are pros and cons to measure, to monitor unfractionated heparin with the APTT. Pros, it is the historical background because the test has been used for many years, for decades, and finally, clinicians are fine with this assay. But as I mentioned also, this historical background is quite fragile just because I mentioned the limitations of the single study on which we rely to determine the APTT ratio. Also, I mentioned that the reagents are the reagent is widely available, and this reagent is quite cheap. So this has advantages. But cons, we have the historical background, as I mentioned, and we have the fact that when you want to use your APTT reagent to monitor heparin, you should determine which is the APTT range corresponding to the 0.3 to 0.7 international units per milliliter, which is quite something cumbersome. And you should do it not only when you change the reagent or when you initiate a new reagent, but also when you change a batch, which is something which is very time-consuming and difficult to do. I don't have the same slide here. I'm sorry. Okay. And one other thing is that the APTT is subject to multiple interferences. On one hand, the APTT is sensitive to the high level of CRP that you may have in patients with inflammation, for example, and this will prolong the APTT. And second, the APTT is also sensitive to the factor levels, the coagulation factor levels, and especially to high levels of factor VIII and high level of fibrinogen. And those high level of factor VIII and fibrinogen, you have them also in the same patients that may have high levels of CRP, the patients with acute phase, but also you can have them in pregnant women. And we know that in pregnant women, UFH is sometimes used just because you can use it more easily, especially at the time of the delivery to protect the woman against thrombosis, just because you can revert it easily with protamine sulfate. Also, the APTT is sensitive to lupus anticoagulant, which is a condition that will prolong the APTT. And one other thing is that from a laboratory perspective, there is no UFH APTT specific international standard, meaning that you cannot standardize the assay. And there is also no APTT specific quality controls. So that would tell you that you are right when you're measuring heparin with the APTT. Even though we can see that in a recent recommendation, for example, they looked at the level of APTT that you should reach, and the goal also for the anti-TNA activity. And as you can see, they mention ranges for the APTT which are independent from the reagent, which is quite something curious, but understandable, just because usually this kind of guidelines or performance nomograms, they are written by clinicians and they may not be aware of the limitations of the APTT. So to overcome these limitations, the anti-TNA assay has been developed. So the anti-TNA assay is a chromogenic assay in which you have your plasma sample in a tube or in a cuvette in the instrument, and you will have factor Xa in excess and a factor Xa specific substrate. And you will mix all together in your plasma sample, which contains the antithrombin coming from the patient and the heparin that the patient has received. And everything will combine, and we will have heparin combining with antithrombin and factor Xa. And as you have added factor Xa in excess, there is still factor Xa which is free that can react with the specific chromogenic substrate. And with that, you will develop a color, and you can measure an optical density which is inversely proportional to the amount of heparin that you have in your tube. The beauty of the assay is that there are calibrators for the anti-TNA assay. There are calibrators for unfractionated heparin with an international standard. There is also an international standard if you want to measure low molecular weight heparin, or you can also use a hybrid curve that can measure both unfractionated heparin and low molecular weight heparin, which from a laboratory perspective is quite efficient because you only have one test for two different types of anticoagulants. You can also use it for danaparoid sodium, which is a drug that can be used in patients with HIT, heparin-induced thrombocytopenia. And you can also use it for fondaparinux, which is the pentasaccharide, the synthetic pentasaccharide, which is this minimal sequence that is required to bind to antithrombin. And you can also measure the new oral anticoagulants, the direct oral anticoagulants targeting factor Xa, rivaroxaban, apixaban, and edoxaban. And for that, you have results in nanograms per ml. There are also dedicated quality controls for all of these different drugs. However, there has been some differences reported across the different assays since a couple of years, because we could suppose that the test is very well standardized as you have an international standard and you have also dedicated quality controls. But in fact, as you can see on this slide, this is a study where you have different reagents here and on the first table. This is the first line, and you have the results with normal pool plasma, which is spiked with various amounts of heparin. And you can see that the results may be different across the different assays. And the same applied with a different exercise, which is depicted here. You can see that you may have different amounts when you measure anti-TNA even with chromogenic assays. So how can we explain? And the same has been also shown here. And why can we have such different? One of the main reasons is that some reagents contain dextran sulfate and others do not contain dextran sulfate. So what is dextran sulfate? Dextran sulfate is a chemical substance that is added to the reagent in order to improve its stability. But in fact, it has also some side effects. And one of the side effects is that, as I mentioned in one of my first slides, heparin will bind to various cells and proteins and then be inactive. And dextran sulfate, when it is present in the reagent, will make free heparin from this binding to cells and proteins. And then you will artificially increase the anti-TNA activity that you measure with your assay. And this is illustrated here, where you have results of anti-10A measured with two reagents, one containing dextran sulfate, which is here on the y-axis, and one not containing dextran sulfate, which is here on the x-axis. And you can see that the one which is here depicted in red that contain dextran sulfate generate higher results than the one that does not contain dextran sulfate. And there is no difference whether you use regular citrate tubes or if you use CTAD tubes, which are tubes which are specifically designed for the measurement, the monitoring of infractionated heparin, because they contain substances. CTAD stands for citrate, adenosine, dipyramidol, and theophylline, which are substances that will inhibit the platelet activation. And we know that when platelets are activated, and this may happen during the blood draw or in the tube, they will release platelet factor 4, and this platelet factor 4 will neutralize artificially the heparin which is present in the tube. But there is no difference whether you use one or the other kind of tubes. So if we look more in details to the supplementation of the assay with dextran sulfate and also antithrombin, just because historically the anti-10A assays have been designed to measure the activity of heparin solutions, aqueous heparin solutions that were prepared by manufacturers manufacturing heparin. And in that case, of course, the solution of heparin does not contain antithrombin. So you have to add antithrombin in your assay to make it work. And the first assays that were designed contain antithrombin. For example, at Stago, we have the Stago heparin, which is an old test, but which is still used by certain labs, because at the time it was considered as a reference, as a gold standard, just because it was the first on the market. And in that case, when you use this kind of test, you will potentiate the activity of heparin, especially in patients who have a deficient antithrombin, because you will artificially make the level of antithrombin higher, and you will artificially make also the anti-10A activity higher. And the dextran sulfate, also I already explained why it generates higher results, just because you free heparin from its binding. So there is a very recent multi-center study that was conducted in 8 hospitals in France to try to understand the differences between the different regions. So this is a study that was conducted in patients of interest, special interest. Those patients with cardiopulmonary bypass 5 to 10 minutes after heparin neutralization by protamine. The second group was cardiothoracic patients in the ICU after cardiopulmonary bypass. There were also medical ICU patients and other medical patients. And they looked at the results in citrate tubes, regular citrate tubes, or CTAD tubes with various reagents which are depicted here that contain or do not contain dextran sulfate. So there were 8 centers, and they enrolled 165 patients, 39 with CPP, 35 with cardiothoracic ICU, 53 medical ICU patients, and 38 other patients. So in total, they performed more than 4,500 measures. So, and those are the results. And the results are perfectly in line with what had been previously observed, which is that if you look at the mean results here with reagents containing dextran sulfate, they are much higher, or they are higher than the results obtained with those reagents here, which do not contain dextran sulfate. And the other thing is that there is also some difference between the citrate tube and the CT tube. The CT tube leading to higher values just because you limit, also you minimize the interference with the platelet factor 4. More interestingly, if you look at the different patient categories, you have here the post-CPP patients, 5 to 10 minutes after protamine neutralization. And you can see a huge difference between the anti-TNA activity using the two different reagents. But if I may remind you, in those patients with protamine neutralization, heparin binds to protamine, and then you only the remaining fraction of heparin, which is free, is still available and is still active. But when you add dextran sulfate to the reagent, then you will make free the heparin from the protamine, and you will artificially increase the amount of free heparin. And this is probably part of the explanation why you have such a difference in those particular patients. But you also have a difference with the other patients. It's less pronounced, but still. So if we look at the clinical benefits of using anti-TNA versus APTT. So this is a diagram showing that in a study where they compared the heparin monitoring with anti-TNA or APTT, they have concordant APTT and anti-TNA values in 2/3 of cases, but there are discrepancies. And what they conclude is that the anti-TNA activity was more efficient to detect overdosing, but also to detect underdosing. So if we also look, I mentioned earlier the interference of CRP in the APTT, and this slide depicts the interference of CRP, especially in ICU patients who are likely to have high CRP levels. Also, lupus anticoagulants, as I mentioned, may interfere, and the high levels also of factor VIII may interfere. And you can see here, for example, when you have increased levels of factor VIII, then the APTT will decrease. This is a normal patient with the white circle here with 100% of factor VIII, and on the opposite, the black circle represents a patient with 600%, which is quite high, but we can have intermediate things, and you can see that the APTT is dramatically shortened in those patients with high level of factor VIII, and this would be the same with patients with high levels of fibrinogen. There are also some benefits in terms of time to reach the therapeutic range, which is more rapidly achieved when you use anti-TNA versus APTT. There are also less dose adjustment, especially in the 24 hours of treatment. And there are also less bleeding events when the unfractionated heparin is monitored with the anti-TNA. Also, from a patient blood management perspective, there are also there is a reduction in the need of red blood cells transfusions when you use anti-TNA versus when you use APTT. Also, in the recent years, we have faced the COVID-19 pandemic, and those patients, they had a very elevated CRP levels, but they also had high factor VIII and fibrinogen levels and a high prevalence of lupus anticoagulants. And altogether, this renders the APTT result quite difficult to interpret for unfractionated heparin monitoring. And actually, it was described UFH resistance in those patients when you used APTT, which is probably less the case when you use anti-TNA, and anti-TNA was considered more reliable also in those COVID-19 patients. From a pre-analytical standpoint, it is also important to remember when to take the blood if you want to interpret correctly your results. So there are two types of infusion of heparin. The first one is a continuous intravenous infusion of heparin. And in that case, you can measure the APTT or the anti-10A activity as soon as you have reached 4 hours after the infusion. And if you use intermittent subcutaneous injections, then you should measure the anti-10A or APTT just at midway between two injections. So pre-analytics also, it has been shown that the CTAD tubes may be beneficial because they will reduce the activation of platelets and the artificial neutralization in the tube of heparin by platelet factor 4. And now we'll move to heparin-induced thrombocytopenia, which is a life-threatening complication of unfractionated heparin treatment. Also low molecular weight heparin, but it's rarer with low molecular weight heparin compared to unfractionated heparin. So there are two types of heparin-induced thrombocytopenia. So the first one, which is type 1, is a mild decrease in platelet count, around 30%, within the first 3 days of heparin treatment. And despite heparin continuation, platelet counts normally recover within 1 to 2 days, and this does not increase the risk for thrombosis. So we don't care usually for this kind of heparin-induced thrombocytopenia. The one which is of interest is the heparin-induced thrombocytopenia type 2, with an important decrease in platelet count below 120 giga per liter, or 30 to 50% of the normal count of the patient. But we have to take also into account the natural history of the disease, because, for example, these patients, they may have, for example, hip surgery, total hip replacement, and in that case, they will start with a very high number of platelets because of the inflammatory syndrome, and then it will drop. And this is not necessarily heparin-induced thrombocytopenia. So it occurs typically between 5 to 14 days after heparin initiation, and the platelet counts do not recover in case of heparin continuation. And what is of particular importance from a clinical standpoint, and this is why it is a life-threatening condition, it is that it increases dramatically the risk of thrombosis. So I mentioned the presenting feature, which is a platelet count below 150 giga per liter, and the onset 5 to 10 days after heparin initiation. But sometimes it can be a rapid onset within 24 hours in patients who have recently received unfractionated heparin. But it has also been described delayed onset of HIT up to 3 weeks after the patient has discontinued heparin. So the thrombotic manifestations are typically venous thrombosis, but more likely arterial thrombosis. And there are also some more rare clinical manifestations of HIT, such as venous lymph gangrene, skin lesions, and acute systemic reactions. Despite the low platelet count, bleeding manifestations are rare, and this is also that we have to keep in mind, even though it can happen, but they are rare. So if we want to do the clinical assessment of the HIT, we have the 40 score, which is considered as a gold standard to look at your patient and to see whether you should or not consider HIT as a diagnosis. And the 40s relates for the thrombocytopenia, the timing of platelet count fall or thrombosis, the thrombosis or other clinical sequelae, or other causes for thrombocytopenia. And according to the description that you have here, you can score your patients with points, and then you come to a score. And if the patient is considered as a low probability of HIT when the score is between 0 and 3, intermediate HIT probability when the score is between 4 and 5, and a high HIT probability when the score is between 6 and 8. And this is of particular interest because this 40 score has a very high negative predictive value, meaning that if you have a low probability score, the negative predictive value is 0.998, which is even more above what you have when you use a D-dimer to exclude thrombosis. If the intermediate probability, if you have an intermediate probability score, then the negative predictive value is meaningless, but the positive predictive value is also meaningless. And if you have a high probability score, the positive predictive value increases, but it's still insufficient to make the diagnosis. So this leads to this diagnosis chart, which is if you suspect an HIT in a patient, you perform the 40 score. And if the score is 3 or below, then you continue heparin. And you have to consider alternative diagnosis just because of the high negative predictive values that we have described earlier. But if the score, the 40 score, is above 4 or equal to 4, then you have to discontinue heparin. This is something very important. You have to start an alternative anticoagulant treatment, which is not VKA, for example, just because you will increase the risk of thrombosis if you give vitamin K antagonist. You have to consider other alternative treatment, danaparoid sodium or argatroban or whatever, but you have to start an alternative treatment, and you have to ask the laboratory to go for tests to confirm the hypothesis of HIT. So now, how do we do the diagnosis of HIT from a laboratory perspective? First, we have a rapid assay, which are rapid immunoassays. So these different assays are described here. You have particle gel immunoassay, you have chemiluminescent assays, you have immunolateral flow, you have latex immunoturbidimetric assays. And those assays, they are designed for a rapid screening of HIT because they have a very high negative predictive value, meaning that if the test is negative, it is very unlikely that your patient does not have HIT, and logically you can restart heparin and there is no need to go for further testing. Then you have the ELISA assay that you can use in every lab, although the format, which are ELISA plates, even if they are stackable in different strips, it's quite expensive, and it's also time consuming because it requires at least 2 hours before you have the result, while with the rapid test, you have it in 5 minutes or 10 minutes. But those assays, those ELISA assays, they are very specific and they can confirm a positive screening test. And finally, you have functional assays and the gold standard, which are the gold standard, but the gold standard among the gold standard is probably the serotonin release assay, but this is also a very specialized assay that requires also the use of radio elements. So not every lab can perform this assay. You have tests based on platelet aggregation, heparin-induced platelet activation, flow cytometry, and heparin-induced multi-electrode aggregometry. But those are very specialized tests, and usually you send over the samples to reference lab to make the diagnosis. So to conclude this lecture, I think you can find more information in our practical manuals. They are here over there on the table, and you can have some if you want. So in this issue on parenteral anticoagulants, you have all you must know about heparin, fractionated heparin, but also low molecular weight heparin. And you have also a dedicated section to heparin-induced thrombocytopenia. We also have a white paper that describes the impact of dextran sulfate on heparin anti-10A activity results. And we have various webinars in our webinar series on this topic. So thank you for your attention.